Just in my defense, I did not study for this quiz.
Well, it's just an interesting quiz. I'm making a proposal that I hope everyone will appreciate. That and of course, obviously, it revolves around healthcare epidemiology. And my title today, which you can't see because I didn't click on it yet. There you go. Nutrition, health equity, COVID-19, and cardiovascular mortality. And so you might be wondering, what does this have to do with it? So that's the beginning of the quiz. Any idea? And can't you unmute some of the audience and get participants?
Yeah, I can. Let me see. Can we mute just I guess a few people at least?
Or let's look in the chat. The question is, what is this?
Okay.
Now, what does it have to do with cardiology? Yeah. So
they look like really huge platelets is what they look like to me. I have no idea. Anyone in the chat, if they want to respond in the chat, anyone have any idea what that is? Help me out. Be my lifeline.
So I've got the chat. So hopefully people, I don't know if you can actually see the chat, but someone.
Fatty nodules.
Okay, at least somebody out there gave it a shot. Okay. So it's a little bit unfair if you're not people. So they're not blood clots, but good try. All right. So without holding people up to, but now you're into it. So there's going to be a few of these. This one is actually smallpox. Okay.
Ooh, okay.
And the reason you're not familiar with it is actually the reason that I put it in the lecture. Believe it or not, the fact that nobody recognized this is going to make my point. So thank you for okay. Beautiful little virus, sort of coming in like a diplococcus, So why is this cardiologist talking about smallpox? Because I'm really talking about ethnic disparities and the fact that we have such horrific healthcare disparities. It's not just black and white. I'm obviously grew up on the south side of Chicago, so I'm going to focus on that, but it's socioeconomic. So you could take, for those of you who live in Appalachia, the Eastern Kentucky, you could just take everything I say about race and replace it with social determinants such as poverty, because it's really much the same. So anyway, this was about Boston. It was really popularized by Ben Franklin because he knew how to publish and he had the respect of everyone. And he started out as an anti-vaxxer, and he got converted after his 4-year-old son got smallpox and died. And so the idea is that, vaccination or inoculation was something that no one had really popularized, and people were dying of smallpox, and more blacks were dying than whites. Why? Really because of the way it spread. It was local spread, and if you were high population concentration, you didn't have a big house where you spread out from someone who was sick, so you would end up with this disease. And it was really difficult in terms of healthcare because it was the 18th century and there wasn't a lot of supportive stuff that you could do. And people were left to either get better or not on their own. And so, as it turns out, there was not a cure, but prevention that was brought to the United States by a slave who was captured in West Africa. You're seeing a picture of him. And he became famous because there actually was smallpox in West Africa. And he knew, as a 6-year-old kid, he understood that if you took took a sharp object, punctured one of these smallpox pox, and took some of the contents and injected it into somebody else, they can get the disease or die, or they would become immune. And the number of people who became immune was way more than the number that died from it. So he popularized it, and he basically saved the lives of a massive number of Bostonians. And if you looked over time, once Onesimus was his name, once they started to popularize or democratize this inoculation process, you could see the death rate just go down further and further. And now, of course, you get to the point where you could show this to a room full of 5,000 people and nobody knows what it is. Unless you were an infectious disease doctor, there's no reason that you would know smallpox. And that is the success of curing disease and eliminating disease. And it's saved a lot of lives, but particularly a huge black-white disparity disappeared. Okay, question number 2. Anybody? I'm going to open up the chat box again. Anybody recognize this?
Is that the Suez Canal?
Oh, historically, you were so close. Geographically, not at all, but historically, so close.
Yes.
Anyone? Beautiful picture. Someone type it in. You can do this. Anyone? Simona? Ben Wu? Barbara? All right. Oh, there you go. Margaret, thank you. Panama Canal. Absolutely. So why is this cardiologist talking about the Panama Canal? Very good. You actually have the Panamanian flag over there. The reason that Suez wasn't 100% wrong is because the digging of the Suez Canal and the way that changed commerce, connecting bodies of water so that ships could pass from east to west, it really made a big difference. And so people wanted to do this in the Americas. All the goods from China wouldn't have to go around the bottom of South America. They'd actually be able to go to the European side pretty quickly if they just could cut a hole in Panama or somewhere else. And so there were many different areas, including Northwest Colombia, that people thought that they could do this. But the narrowest turns out to be very near Panama City. And the French were really, because of their experience with the Suez Canal, they thought they could do this. And they were digging the trenches. And this is what it looked like. Now, you have to think of it. This is the late 1800s, okay? And the emancipation of slaves a little earlier in the Caribbean than it was in the United States, but still, you had many Black people who were poor, who were emancipated. And the idea that you could take a boat from the Caribbean, get down to Panama Canal, make money as a laborer and send it and feed your family sent a lot of people in that direction. Some of them died trying to get there, but many, many people, and you can see on this picture that most of the workers are Black, okay? And every picture that you have, trying to clear all this material, to dig this, basically the biggest ditch ever, your people are working day and night. And then the trouble started. And that was when you're digging ditches, you're going to leave water everywhere. And when you leave water everywhere, mosquitoes are going to come. And if you have the wrong type of mosquito, you could actually come up with a large number of people who have no way of protecting themselves, essentially, and they end up with a lot of deaths. In this case, it was yellow fever. This was so bad that the French, as important as this digging this was to east-west commerce, they got to the point where they said, this is not worth the human casualties. So we're going to stop. And so they basically stopped the Black-white differences just by quitting. And so late 1890s, they stopped completely. Well, it turns out this was the mosquito that was so good at spreading this particular disease. And this particular virus that it was spreading it would require that a person was bitten. That particular species of mosquito would then transmit it to the next person that they bite. And so it turns out that the United States in the 1890s actually had a war, the Spanish-American War. And the Spanish-American War was not known for its big battles and combat and mortality like the previous war, the Civil War. And this was actually a war where more people died of yellow fever and malaria than actually from combat. And so it turns out that the United States military had a huge interest in not having soldiers die of these infectious diseases. So they were studying them really hard. And they figured out this mosquito. And so Major Walter Reed, his colleagues, George Dangus, these people actually figured out that mosquito abatement could stop this from happening. So you take all of the ditches and all the water and you put oil on top of it. You do everything you can so that the mosquitoes can't reproduce and the disease goes away. And so that's what happened. You know the rest of the story. The United States went back about 10 years after the French gave up. They completed the canal. They rented it from, but the original terms were $100,000, which was reasonable in 1905. In the 1970s, that was a huge mismatch in terms of the amount of money the United States was making over it. And then Jimmy Carter gave it back after in 1976, which was the right thing to do for the Panamanian people. Anyway, huge black-white disparity eliminated by eliminating the disease. Okay, let's do another one. Anyone? Tell me who this is.
That one I know. I'll let other people guess.
And so which disease am I going to talk about?
Polio.
There you go. Oh, I think it's on the slide. Bad quiz maker. You could take these artistic virus electron scanning EMs and make them look beautiful, but this was not beautiful at all. Unfortunately, because of our racial and socioeconomic structure in this country, this became a huge black-white disparity. And growing up on the south side of Chicago in the 60s, I actually had friends who had polio. And the polio vaccine came out in really the late 50s. By 1964, we had 3 of them. You could take them orally, you could take the injections. But the whole idea is that once people were inoculated, you could knock down this disease. And once you knock down the incidence of the disease, it's really hard for it to spread. Now, the racial side of this one wasn't just getting the disease, which was worse in the Black community because of proximity. People in proximal location to each other is how it spread. This was, fecal oral, so stool, contamination, that sort of stuff, which happens more when you're poor and when you live with a lot of other people. Okay. And so, as it turns out, there was a huge disparity in the incidence, but what was worse was the treatment. That is, there were beautiful, big recovery facilities and iron lungs that were out there for the population, but it was very hard to get treatment for this if you were Black. That's something that everyone knew about because of the president, and leader of the free world, having this disease. So you could argue that more resources should have been poured in, abatement, moving, sanitation, do every public health thing, make sure that there's equal opportunity for sanitation and for recovery. But that was not where we were as a country in the middle of the 20th century. And so more Blacks suffered. Well, how did we stop the Blacks from suffering? Just get rid of the disease. Okay. Anyone want to guess on this one? It's a little more modern. See, it's a color photo. To meatballs. I don't see people coming in. Okay. All right. I bet if I show you the next one, you'll see it. Definitely anorexic. Okay. That is HIV. And there you go, Mona. Good job. Okay. This is actually the HIV virus. It's a retrovirus. And this is an amazing thing that hopefully everyone is familiar with. We still have it. It hasn't been eliminated. And it's just hard to imagine that when I was an intern at Grady Hospital, one of my third-year medical students contracted this. And he had all the risk factors, but nobody knew what the disease was. And he ended up having Kaposi sarcoma and dying of pneumonia. And this was a horrific blight that was really spread a lot more in Africa and in the African American population. It's still here. There's still racial disparities, but hard to imagine that this was 6 months later. Same guy. What's the difference? Was treatment, antiretroviral therapy. And I got to know, many of you know that I used to play professional tennis, but I was actually I never maximized my potential because I quit and went to medical school. But my hero back then, of course, in the early 70s was Arthur Ashe. I got to meet him as he was a visiting professor at University of Chicago when I was on faculty there, and had dinner with him and the president of the university, and talked about a lot of things. And during that dinner, as he's waxing philosophically on many things, he's taking like 17 different pills during dinner, and he had to do that multiple times a day. And that was 1993. Imagine what happens when you come up with a therapy that people can do really preventively. There are medications that you can take weeks apart, and you will actually control this disease and get it to the point where, as you see on all the television commercials, that someone has a normal C4 count. That means the immune system is fine, and the virus, even though they have it, is undetectable. And as long as it's staying dormant like that, it can't spread. And so you could look at this huge black-white difference, which is absolutely astounding, and see what happens over time. It's still there, but it's going away. And it's not just and that's because we're able to remove the mortality by getting rid of the disease and managing it. Okay, all right. So anyway, enough with the quizzes. This is, but I do wanted to bring into the idea, and I think you see where I'm going with this. You're all connecting the dots. That this cardiologist is going to say that cardiovascular disease is one of these, but it's not just cardiovascular disease. It's actually COVID-19 as well. And so this is our mortality in the United States. You saw the multiple peaks, you saw the multiple variants, and you also saw that this spike protein, we could take a vote on which virus you think is the prettiest. I'm going to go with smallpox. But the real issue is, what kind of damage did it do on a racial basis? It was horrific, particularly in the beginning. It was particularly difficult for those of us who are African American, some leadership capacity, being told by people in our community that they shouldn't get vaccines, and that this whole thing was something set up to get rid of people of color. Well, the people of color were suffering. No question about it. And a lot of the lessons that we've been talking about this morning were present. That is, people were working manual labor jobs, and they couldn't just stop and start seeing patients at home, which I did. I could hunker down in my condo and essentially do my job as chief of cardiology at Rush and see all the patients remotely, and everybody got their care. But most people in my community didn't have that kind of option. And so you saw numbers like these, that there's a huge black-white differences. And when you look at, it's not just race, it's poverty, And child mortality is still an issue. American Indians were actually worse than African Americans. And so any population that has difficulty with healthcare access suffered more. And so we were analyzing our COVID database at Rush, and we just got scooped. So you don't see our names up here at the New England Journal of Medicine. Oshner actually did a great job, and Ebony Price Haywood put together this data, but her results were essentially exactly the same that we had, and that is that 77% of the people were hospitalized, okay, and 70% of people who died were Black, and that was more than twice the ratio of the population. But if you take race and you put it in the mix statistically with the amount of hypertension, obesity, diabetes, poverty, education, you put all those things in the model, Black means nothing. It was nothing. It wasn't that Black was a risk factor. It was that the Blacks had risk factors. And so it was risk, not race, if you adjust for all of the clinical and sociodemographic characteristics. They got a hazard ratio, for those of you who know what that is, of 0.89. That, if you don't know what that means, that would be 11% protection from being Black. Probably a statistical quirk, but when we analyzed the data at Rush, it was 0.79. It was a 21% protection of Black by being Black, meaning Black actually meant you were more immune to dying from the disease if you didn't have the poverty and the obesity and the diabetes, high cholesterol, and underlying lung disease, et cetera. So the idea is that, yes, we did good with COVID. 3 years later, a lot of people died. A lot of people died unnecessarily. And there were huge Black-white differences. But you're not seeing that now. Why? Really because of the vaccine and all of the things that we did as a society, and healthcare workers and every person who put on a mask contributed to stopping the spread of the disease and somebody dying. And so public health and our healthcare system, and we put all that together, and you could eliminate a huge Black-white difference. Okay, so what I've been talking about now for quite a bit is really about trying to achieve health equity. Racial health equity is a major, socioeconomic. These are major issues that we have to face as a society. So many of you have seen this cartoon before, the difference between equality and equity. But I'm going to give you a couple of variations. Before I give you the one that I really think should be happening, I saw this one, and that is reality. And this is something that we have to be sensitive to, that folks who have in this society have more, and people who have not, usually a hole is dug. And we've got to do better to achieve health equity, because it's in all of our best interest. As long as we are one society, one country, we really need to do better with all of our disease entities. Okay, so here's my proposal in the form of that same cartoon, and that is healthcare justice. Just remove the fence. And so been at this for 30 minutes now, and all I've talked to you about so far is removing a bunch of fences, whether it was 17, 18, 19, or 20th century. When the fence was removed, you may have other problems, but the problems that I've shown you this morning are gone or are so small that we've done so much better. So anyway, I would like to shout out to University of Louisville, people saying, why did you ever leave Rush? And I was really attracted. It wasn't so much about being a department chair or moving up the academic ladder. It was the opportunity to go into a place that was very focused on health equity, coming from the president of the university, she's moved on, but and we have a new president who is equally focused on health equity. And so to be a partner in that, and it just means I have to wear a lot more red than I used to, but it's really a pleasure to be there at University of Louisville. Because all the forms of inequality and injustice in healthcare is the most shocking and inhumane. And so I'm going to talk to you really about the issues around food, because I think of all the things we could do, the one that's so immediate, the low-hanging fruit, no pun intended. Yeah, the pun's always intended, particularly that one. If we say low-hanging fruit and vegetables, we could do so much better with cardiovascular disease and healthcare expenditures, and that would actually leave us more healthcare or more financial resources to do things with housing and neighborhoods and education. We could actually fix a lot of everything else if we fix this one. Okay. And so I've been talking about cardiovascular disease and COVID, polio, and all these things, but it really doesn't matter what you look at. In our society, in the United States, people of color fare worse than their white counterparts, no matter what. And so a lot of our organizations, including 2 weeks ago, the American College of Cardiology, are doing everything we can to try and focus our organizations and our institutions on health equity. So we have the cardinal principles that I'm inheriting, and at the American College of Cardiology, really trying to get everyone to have a fair opportunity to be healthy. I would recommend this website, going to the American College of Cardiology website. You don't have to be a cardiologist. You can look at what we talked about in the Health Equity Summit and defining health inequities, how they exist in cardiology, but as a view of how they exist in the United States completely. And then sort of a roadmap for the things that we can do, creating a better culture, prioritizing it in all of our organizations, aiming at eliminating these disparities so that people have equitable cardiovascular care. Why is it so important? Why start there? Well, you're seeing it on this slide. And that is, we have a horrific amount of cardiovascular disease burden in the United States. It's very expensive, not just in terms of billions of dollars, but in terms of the number of people whose families are destroyed. And then that fifth bullet point, that over half of all African Americans have some form of cardiovascular disease and have a 21% higher cardiovascular mortality. And again, I will, here is a shout out to all of my, if I can get back there, a shout out to all of my cardiology colleagues, starting just when I went into medical school in 1975, but I can't take credit for any of this. Excuse me. But starting in 1975, about the onset of bypass surgery, and stents followed in 1979, and you developed statins and ACE inhibitors for heart failure, and you add one therapy on top of another therapy. And we ended up with about a 70% decrease in cardiovascular mortality. You would think that would have put us at number 2, and we almost got there. But in 2015, it started actually going the other way. I always was going to throw in a little bit about poverty, because here is Eastern Kentucky and West Virginia, and you can see the very dark, the very high amount of cardiovascular mortality, and all cause on the left, heart disease, premature mortality on the right. And so it isn't as much about being Black as it is about having socioeconomic deprivation, starting with the redlining in neighborhoods and poor education, which put you at lower jobs, less vertical transmission of wealth. And so generation after generation ends up suffering the same set of diseases. And one of the things and you could talk about access to care stress, low education and poverty, but unhealthy lifestyle is the thing that's common to most of our people, whether it's Native Americans, eating soul food when you're African American, having really the kinds of high fat, high refined grain diet that you see in poor people throughout the United States. And so you end up with more cardiovascular disease and more blight. So what can we do in the cardiology space to try to make this better? A really nice article put out about 9 months ago in Journal of American Medical Association that talked about every aspect of this, the racism, the sexism, the poverty, and to try to first to get cardiac disease in order, you have to know that it's there. And that's where diagnostic imaging and access to diagnostic imaging is really important. So we continue to have, this is using their outline from Sarkar's article in health inequity and healthcare access, which I'm going to talk about. It's happening across so many communities. And I'm going to give you some concrete examples. There are areas where you just can't get an ambulance. And I was in one of those areas. It was Detroit. Had a wealthy person saw some of the data and gave 60 ambulances to the city of Detroit while I was at Detroit Receiving, running the coronary care unit. We thought it was going to be great that I thought that our, door to balloon time, which many people have heard of, is time the person gets to the emergency room. You find out they're having a heart attack and you get them to the cardiac catheterization lab and open up that artery. Okay. And the door to balloon time was excellent at Detroit Receiving Hospital. The problem was that the onset of symptom to getting to the door and therefore symptom to balloon time was terrible. So anyway, so what did they do with the 60 ambulances? Hardly anything, because they didn't have ambulance drivers. They were taking up collections from the public for a police officer who had 3 kids and couldn't feed them all because they were missing payments. So things are better in Detroit, but you could talk about Flint, Michigan, and the water. There are issues that we shouldn't have as leaders of the free world in our own society, and they do play out, particularly in cardiovascular disease. But when we talk about health access to care being poor in this country, I want to really change the dialogue just a little bit, or change the jargon. That is, we need to improve healthcare, lower costs, better care. That's the so-called triple aim. We've added to Don Berwick's triple aim. Number 4 is actually doing a better job of caring for the healthcare workers. A lot of burnout. We need to address that. But we also have to deal with health inequities. And he wasn't really thinking, you kind of think about what would happen to health equity if Don Berwick's triangle or triple aim was actually taken seriously. They would all improve. Okay, so people talk about access to care, and I'm saying it's actually 3 different things. Number 1, there really is poor access to care. There's longer wait times, fewer providers, less diagnostic tests, and less subspecialty care in our own society. But then there's also access to poorer care. And I always joke, not a joke at all, that I don't get upset when doctors don't follow guidelines unless I wrote them. And I can look back at my career at writing nuclear cardiology guidelines and hypertension and then primary prevention, which I'll talk about today. Primary prevention guidelines, the nutrition section. If people would actually pull up that document from 2019, read section 3.1, and look at the data that underpins those recommendations and change their diet, we could eliminate, heart disease as a major killer of Americans in a couple of weeks. But people are not paying attention to the guidelines. So accessing to poorer care when you have poor provider adherence to guideline-driven management. They're not telling people the right things. Doctors are dying of, and particularly cardiologists are dying of heart disease because they're not following the guidelines that the American College of Cardiology and American Heart Association have published. And then there's accessing care poorly. And that really has to do with are issues of having good advice from a good doctor who's available, but poor adherence, poor lifestyle choices. A lot of that is due to health literacy issues. They're not understanding the importance of hypertension control, for example. But some of it, we really have to look at ourselves, saying this as an African-American man. The idea that African-American men have such poor adherence to therapy unless the advice comes from an African-American male. Well, I can understand that on the one hand, and I can resonate with it, but we've got to fix that because we just don't have enough African-American men who are going into medicine. That gap is not closing as fast as it should. Okay, so access to care, when people say that, I say, which one are you talking about? Okay, so this is one that I was kind of shocked at. You're seeing the Journal of Cardiovascular Computed Tomography. So I'm using this as an example of diagnostic imaging, but if you wanted to pull it up and for a more full discussion than I'm going to do this morning, you can see the publication reference there. And this was where I asked Michelle Ikram, who was my research assistant back when I was at Rush, and you know, I was complaining with that Rush wouldn't give away the coronary calcium score, which many of you know is a really great screening test. And then all the data came out and said it's better than we thought it was. And then you know, if you have risk factors, you probably should get your calcium scored if you don't know that you have heart disease already. And then it turns out that in our 2019 guidelines, we actually recommended it as a screening tool for people who are not low risk, or even at the high risk. If you're high risk, you don't need it. You need the treatment. But that intermediate zone, which is a lot of people who are above age 40, they really do need this test. The problem is it's not paid for by insurance. And so what can you do? If you have $100 or $200, depending on where you go, you can get this test done. There are places in Chicago, I don't usually name names, but the Advocate system where it was only $49. And that's a little more accessible, but they're mostly in the suburbs. And so what could you actually do if you had this test recommended, but you don't have the $100 to put down and come to Rush? Well, so I was trying to convince Rush to actually give it away for free. And didn't get very far. And so I said, okay, let's give them data. Rush is a great place. They respond to data. So I was going to ask Michelle to say, we're going to do the pricing of coronary calcium because I think it's putting people at risk. You know, if somebody's a CEO and they're coming to see me because they saw me in some movie, great. They don't have any problem getting a coronary calcium. But the people from the neighborhood where I grew up, this is rent, it's food. $100 is a big deal. Okay, so anyway, she put together the data for all 40 hospitals in the Chicagoland area. And it turns out the average wasn't, that Rush was not out of line. It was actually right in the middle. It cost about $200 on average in our area. But when she gave me the data, I said, Michelle, you're not done. She says, yeah, I'm done. I said, I see 5 hospitals missing. They're all the ones in the neighborhoods that I grew up in. I said, well, first of all, why did you grow up around 5 hospitals? Well, we were really poor and we had to move every year because they wouldn't renew the lease. Okay, fine. But don't dig into my past. Tell me what happened to these hospitals. It was Jackson Park, South Shore, St. Bernard's, Roseland. Where are they? She says, they don't offer it. So we were just stunned that we could actually have a test, which is a core portion of our 2019 prevention guidelines, has a very defined role that needs to be applied to a population to save lives, and it's not available. So we then, being this closet statistician that I am, started taking all the data, and we went into the census data, and what we found is that there was a relationship between poverty rates, household income, life expectancy, population density, and degree of higher education, and whether or not you can get a coronary calcium score. This really shouldn't happen. But when we're writing up the manuscript, you have to do a literature search. We're finding that they're all over. That use of echocardiograms or X-rays in inner city hospitals versus suburban hospitals, they're all very different. So you have access to care issues, and then you have systemic issues that can limit diagnosis. And without an early diagnosis, people are going to suffer. Then you have, of course, all the issues that I mentioned with health literacy, where people do not recognize their symptoms because they don't have the education that lets them know of what it is that they should be looking for and when is it time. If I heard one more time that XYZ disease was worse because the patient came in late presentation, whether it's breast cancer, stroke, or hypertension out of control. These are issues, and I understand that people would rather deny than miss work because they not going to be able to pay their rent. They're living from paycheck to paycheck. So this is the intersection of society and health that makes it really hard. But then we have the biases in optimal care. And this is something that really needs to be addressed. I think many of us are addressing it, such as the American College of Cardiology and University of Louisville, but it would be great if everyone was paying attention to it. That if you look at optimal therapy, such as giving clot-busting medicine for stroke, getting it to the poorer people, the Blacks, Hispanics, and Native Americans, is far less likely. Why is that? That's implicit bias. And the implicit bias is something that everyone can test. You can just go on the implicit bias website from Harvard, and you find out things about yourself that would be very helpful for you to know. And every person who's in healthcare needs to be able to do this. Because if you don't gather the information, you'll never recognize it, and then you can't combat it within yourself. And this data has actually been out there for a while. The very famous Serena Williams had a pulmonary embolism after she won Wimbledon and cut her foot in 2011. And so once you've had a DVT and a PE and you almost die, you kind of know what the symptoms are. So then fast forward to 2017, and she is actually 6 years later pregnant, has a baby, and postpartum, she's getting the DVT again. And she recognizes the symptoms and asks them to get an ultrasound. They said, no, you're just fine. You're okay. It's not a problem. Well, then, she gets another pulmonary embolism. Well, that's really inexcusable. But that is unfortunately, and you could, turn it into a television show to get people to recognize that Black women are under listened to. But that's actually been in the literature for a while. This is New England Journal of Medicine 25 years ago, where Keith Shulman actually went to 2 large medical meetings and asked doctors, come on over and take this quiz. And they gave the story of unstable angina with 8 different actors. So Black, white, old, young, male, female. And if you give the 8 actors the exact same story with the exact same hand location, fist clenched over the middle of the so-called Levine sign, and it's clearly unstable angina, and this person needs to go to the cath lab, it turns out that the odds of you getting that recommendation was really high if you were white and male. But if you weren't, the percentages started to go down. And if you were an older white female or Black female, you ended up with a very low rate of cardiac catheterization.